Hello and welcome to this new episode of The Graft, this time with Dr. Toby Eyre, who is a consultant hematologist and clinical researcher at the Oxford University Hospitals, specializing in the management of lymphoid malignancies. He is an international expert in the management of lymphoma patients and patients with chronic lymphocytic leukemia. We talk about CLL, its past, present, and future, about his career, and about training and the COVID pandemic in general. And now, enjoy the conversation with Dr. Toby Eyre. Funny first question, maybe. Do you remember your first patient with CLL?
That's a great question. No, I don't. But I think from my early training days, you kind of tend to remember people who kind of really stick out. Actually, I did my first part of hematology on a bone marrow transplant ward. So I kind of remember the inpatients from there. And obviously most of those weren't CLL patients. So I wouldn't say I specifically remember my first one, but I certainly remember some interesting hematology patients going back to the start.
And why did you choose hematology?
I chose it because it was a great mix of interesting science, biology, new treatments, and kind of patient contact, which felt very individual and personal. So I felt that you had the kind of level of patient relationships that people get in, say, primary care, for example, with their general practitioners, but also you had the kind of interesting science and research to go kind of alongside that. And I think that's fairly unique actually in hematology. I think we're very fortunate to have that combination of factors in our specialty.
And would you outline maybe a bit your whole career, maybe from why did you choose medical school and how you proceeded onward from that?
Yeah, okay. So decided to go into medicine kind of mostly by chance, I suppose. My father is now a retired general practitioner, and I suppose subconsciously I thought clearly doing medicine was a kind of interesting thing to do, because we used to kind of talk a bit about what he used to do and so forth, and I had a lot of respect for him. And then, so you know what it's like. You kind of decide at the age of 16 that the medicine might be a good idea without having any sort of clue really what's involved. I did a little bit of kind of a taste a week. I nearly fainted watching a hemicolectomy, I remember, when I was 16. And then applied for medical school, got a place, and kind of went from there really. So in terms of kind of my time as an undergraduate, I wouldn't say I did anything kind of dramatic or different to other people. It wasn't really until I qualified and was in my second year as a kind of junior house officer, they're called in the UK, or resident, I suppose, in the US, where I met a hematologist who kind of took some time to kind of talk to me about his specialty, actually. And I did a bit of time out of my training just shadowing him and the hematology department I was with for a short period of time, and really sort of fell in love with it. I really enjoyed the pathology aspect of undergraduate medicine, but it was really kind of in that second year post qualifying that I really decided that was what I wanted to do. And then actually, I suppose that's still relatively early on in terms of a career to know, I definitely want to be a hematologist. So that was really helpful for me, because then I could sort of focus my interest and so forth. And came to Oxford to do my registrar training, did 3 years research in early phase clinical trials. So it's a kind of mostly clinical based research attachment that I did out of program, and then got a consultant post here, and now lead the CLL service and the low-grade lymphoma service, and have a great interest in both education, but also clinical research and clinical trials particularly. So combination of things. So yeah, lots of lots of kind of things sort of fell into place along the way, but I'd say it was from really quite an early stage. I thought hematology would be great. I didn't know that I definitely wanted to do lymphoma and CLL. I think the reasons for doing that are predominantly because of the sort of the people I met along the way and who I was inspired by, and what I kind of felt was a really nice area to get involved in. So yeah, that's sort of my path to date, I suppose.
And you all already hinted to that, but maybe if you can outline that a bit more, or fix that, when you look in retrospect, and you said there were like people who influenced you, but was it basically their character, how they approached the hematology, or was it just really how they presented the content, or what was it?
I suppose it's a combination of factors. I wouldn't say it's one thing in isolation. I suppose, and the thing is everybody will get different experiences from characters in their own unit, but certainly the kind of enthusiasm for clinical research within the lymphoma and CLL team, I was always kind of very inspired by as I came through. Also, the desire for individuals and people more senior to me to see me develop and see me succeed in different aspects of my training, and then kind of after that subsequently, I think is really helpful. Everybody needs sort of supportive mentors, and I suppose that's what I had within the lymphoma service and lymphoid service, and so that to my mind was always really important as a trainee going through. I think it's vital that anybody gets support from people who are sort of more senior than them, and kind of is their voice and their kind of to support them through their training. So yeah, that's probably, it's a combination of factors. I think I saw in lymphoma and CLL, I saw this real shift in what was happening. Probably about 10 years ago, we had the advent of things like PD-1, brentuximab, BTK inhibitors, then BCL2 inhibitors came along, and all these therapies really, if you look at them from a kind of timeline perspective, they've really come in the last 8 to 10 years. And I suppose that came through as I was training, and whilst lots has happened in myeloid disease and other areas, I think my personal bias certainly is that the lymphoid, the changes we've seen in lymphoid malignancy have just been extraordinary in such a short period of time. And it's just been fantastic to be kind of in and amongst that. When I was a trainee and a fellow doing my research program, we had, for example, the nivolumab study open, the phase 2 open. We recruited well in Oxford, and I got to use kind of sort of PD-1 inhibitors before anybody else in the UK, in Hodgkin's at least. And then we had the venetoclax phase 1 and 2, well, it's phase 2 studies open. So I had early experience of venetoclax as well, early experience of acalabrutinib and so forth. So I kind of really enjoyed that aspect of being sort of at the forefront of actually at least the clinical kind of trial development, and still do actually. I've treated a lot of patients with pirtobrutinib, LOXO 305 recently, and it's been fascinating and fantastic to be sort of at the forefront of some of that drugs development. So yeah, they're the aspects of kind of clinical research I really like as well. So I think that's probably overall, I think that's inspired me in this field particularly as well.
We will come hopefully through to all these aspects you just mentioned with respect to CLL, but maybe just two questions before that. One question, and the first one, because you said you started quite early, you are quite young, and when you're quite young, you sometimes have moments where you just say, okay, do I really want that, or is that what was there a moment you thought, okay, I don't know, is it worth it?
Definitely. And obviously there are many paths people can take in hematology, both malignant hematology, non-malignant research centers, big tertiary centers or smaller district general hospitals. And I think, the workload, the demands, the impact on your day-to-day life is different in those different fields. And, each are of course valuable in their own right. But I think there are different pressures. And yeah, for sure. I mean, I think you have to be honest with yourself about what sort of gets you out of bed in the morning and what you really enjoy. And that will be different for everybody. And I think, people need to certainly respect each other's decisions when you're deciding, oh yeah, I want to, work in whatever center, I want to do this. I don't want to focus on research. I do, all this kind of stuff. And I think it's difficult because I think, what you might want when you're, say, in your mid-20s might not be what you want when you're 40 as well. It's quite hard to kind of think too far ahead as well. But no, I've not kind of regretted so far my decisions. But I do think it's quite difficult. And for sure, there have been times during my training where I thought, oh, am I good enough to do kind of research? Will I be able to kind of sort of come up with new ideas and develop research projects and proposals and publish, all this kind of stuff goes through your head because, in some respects, unless you've been, very inspired and published loads when you were either an undergraduate or very early on in your career, you might not actually have a really good feel for whether it's something you're either good at or have the energy, motivation, and sort of desire to do, I suppose. And that's quite difficult, actually, because you sort of have to be really honest with yourself about what you think you'll be good at and what you think you might not be good at. And actually, I suppose I did that in terms of my decisions around my research time, in that I did a little bit of laboratory work, but I didn't do very much. And that was, I suppose, me being sort of really honest with myself in that I didn't really see myself leading a lab per se. And I think I had to be really clear with myself in my mind at that point that was something that whilst obviously a lot of the laboratory research is really critical, I didn't really see that potentially as my own personal sort of strength. And actually that's been okay so far in many respects. It means obviously you need to work with people and work with the right people and so forth. But I think you're right. I think you're right. You kind of sort of have to be really honest with yourself and think about what your own strengths are. Think about and think about what you actually want as well. It's not easy. I don't think if you spoke to anybody, they'd necessarily say that they were absolutely certain during the initial phases of their career exactly what they wanted to do. I was just fairly lucky that I knew I wanted to do hematology, and it was pretty clear to me from quite an early stage. I think that was fortunate. But yeah, within the decisions around research or not, lab or not, clinical research, etc., that was less clear for at least a period of time. But yeah,
you perfectly outlined the response for my second question, because you were early involved with clinical research, and for many trainees that is exactly the question you answer yourself early in career. Okay, do I want to do research or just clinic? And if I want to do research, how do I integrate this in my workload, etc., etc. But you perfectly outlined that, and this is was basically a no-brainer for you, as I understood it. This was just okay, yeah, I want to do research, and how do I integrate it? That was more the question, right?
Yeah, I think I always thought I'd want research to be a part of my job. I don't think I ever thought, oh, I'd necessarily have to be a full-time researcher or anything like that. And I'm still definitely not that. And in fact, it's quite challenging working in the NHS, actually, just finding the time to do research. Actually, the kind of clinical jobs that are available in the NHS actually don't particularly lend themselves very well to actually integrating a lot of clinical research into, you know, job plans and so forth. So but yeah, I think I always had a sort of inquisitive mind and always liked the kind of new stuff that was coming through. And, you know, when there was like a phase 1 study published, I'd be like, oh, what's this drug? This looks quite interesting. What does it do? How does it work? You know, this kind of stuff. So I suppose I was inquisitive enough. I think you have to be inquisitive, and you have to like the idea of thinking up a project, an idea, and running with it, and kind of galvanizing people around you to kind of make it work. And you've also got to be a kind of completer finisher as well. You've got to be somebody who like has an idea and finishes that idea, because I think that's a really important thing when you're, you know, actually trying to be productive and so forth when you're doing clinical research. So yeah, I think it's a lot of factors that are important, but I think overall you've got to know that you want to do it, basically. I think if you're lukewarm about it and you're like, well, I'm not sure, yeah, it's quite interesting, but maybe it's not for me, I think then it's probably not for you, because you've often I have to put in quite a lot of my own time into it, and, you know, work late when the kids are in bed, etc., that kind of thing. So, you know, there are quite a few sacrifices that kind of come with it. So you got to want to do it, because if you don't want to do it, there's no, you know, you're not going to.
Well, and when we come now to CLL, if we are today and a patient with CLL presents to you, how do you approach this patient? And when you compare that, you already alluded to it, but maybe you can try to elaborate on it a bit more. When you compare the past and the present you experienced, what changed the most for these patients? If you compare a patient now from a patient 10 years ago, for instance.
Well, I mean, I think it's fair to say there's been a revolution in therapy in CLL. I think there'd be no exaggeration there. You know, if you go back kind of pre-ibrutinib, we had no kind of targeted agents, particularly in CLL. And in the last kind of 10 years, we've had ibrutinib, acalabrutinib, the PI3 kinase inhibitors, zanubrutinib's coming, novel CD20 antibodies. So obviously we had rituximab going back further, but, you know, obinutuzumab, clearly a more effective CD20 antibody, BCL2 inhibitors more recently, clearly changing the treatment paradigm further. And now we're going to enter the non-covalent BTK inhibitor era too. So we've had, just when you think there isn't another kind of trick up our sleeve, we've got another novel agent that seems to work very nicely in CLL as well. And so, you know, we've clearly undergone transformation in a very short period of time. So yeah, if I think back in kind of, you know, think back to say 2008, we were giving lots of people FCR, we were giving people bendamustine, rituximab, a fair amount. We were giving chlorambucil with rituximab. You know, so our chemo in the frontline setting, and then people were doing things like allogeneic transplant in so-called high-risk disease. You know, and that was generally defined by your length of remission to FCR, going back now 10 years. So if you had a P53 deletion mutation, or you had a short remission to FCR, allo was being considered fairly early in the treatment pathway. And, you know, similarly, chemotherapy was used after frontline chemotherapy. So you would use chemotherapy with an antibody at relapse as well. Now, of course, you know, lots of centers had clinical trials open, and so we were starting to see early signs of some of these newer agents coming through. But, you know, in all honesty, you had our chemo, then the only novel agents, so-called novel agents at that kind of early stage, were drugs like ofatumumab, which was used in people as monotherapy, in people who are kind of quite heavily pre-treated, and alemtuzumab was actually used a fair bit in patients who had P53 deletion or were refractory to chemotherapy, and that was often used as a kind of bridge to allogeneic transplant. So you can see how far we've come. So I remember giving monitoring people for CMV with alemtuzumab back on our day treatment unit, trying to bridge them to allogeneic transplant in a kind of pre-targeted inhibitor era. But yeah, we were lucky in Oxford as well, because we had quite a lot of the early studies with PI3 kinase inhibitors, with BTK inhibitors, and then with BCL2 inhibitors. So we had a bit of a sort of glimpse as to what they were doing clinically. And that certainly, so I suppose early on, whenever these kind of studies were open, there was certainly a desire to enroll people into these studies, because I think it became clear relatively quickly that these agents were going to be pretty game changing.
And you talk about like treatments, but is there I imagine always like intertwined relationship of understanding the disease better than we did like 10, 15 years ago, and then try to develop treatments. So what would you say changed the most when in understanding the disease and maybe even patient selection, for instance? Or could you allude on that a bit more?
Yeah, it's a good question there, because of course we've kind of developed greater understanding of the disease, but we've kind of known for quite a long time the B cell receptor pathway and the BCL2 kind of anti-apoptotic pathway have both been kind of important. But I suppose if you take the B cell receptor pathway, we've tried a number of inhibitors of that pathway for a long time, and we just happened to strike gold with BTK in many respects. So the biology, yes, has been important, but we tried SYK inhibitors, PI3 kinase inhibitors. We tried to target mTOR, various AKT inhibitors. So there've been all parts of the pathway which have been looked at and targeted, but BTK actually, not necessarily because people thought it was biologically more important to target than say SYK. But we just sort of struck gold there, I think. I mean, maybe that's too simplistic our understanding of it. But sometimes actually the clinical behavior of responses to treatment tell you as much, if not more, about the importance of a pathway than necessarily the other way around, which is kind of interesting, isn't it? And then I think BCL2 it was just once BCL2 inhibitors started to be used and the efficacy was seen with the early BCL2 inhibitors, it just became apparent that you needed a BCL2 inhibitor that wasn't going to cause issues with thrombocytopenia, and that you had to use it very carefully. And then I think it became apparent that it was highly effective. But it's interesting, isn't it? BCL2 inhibitors, you think would be extremely effective in follicular lymphoma. They're not. The biology of the disease would tell you they should be really good. That should be the disease entity that actually they changed the game in. They haven't. It's interesting, that, isn't it? So it's not, so sometimes not always, but sometimes the kind of clinical features of how the diseases respond to these agents sort of trump what we think should happen biologically, which is kind of interesting, isn't it? And shows actually, how much we still have to understand. But so I think it's a bit of both. But at the end of the day, the drugs have to work. They have to be tolerable. They have to have a broad biological rationale, and then I suppose you go from there, really.
Yeah, but I really like what you say, because as a trainee, CLL always was for me a quite clinical disease. It was exactly what you just said, and I'm early this week. I made for me I made the experience that I thought about BTK inhibitors like the NOACs in cardiology, where you now have many of them, and each of them is more like specialized with less adverse events, etc. So this is really a clinical game changer, where we just have a target and we perfect the adverse event ratio, the efficacy, etc. So would you maybe outline a bit what you already mentioned? Ibrutinib was the first one, but now there are like acalabrutinib, zanubrutinib, pirtobrutinib. What are the big differences between the new developments, and what was the rationale?
Yeah, it's a great question. So I thought it's interesting, when ibrutinib came along, it was such a game-changing drug. People thought, subconsciously, I think thought, oh, well, CLL sort of now sorted. That hasn't quite been the case, and I suppose it's been very interesting just to observe that there has actually been space in the market to develop, second, third generations of these agents. Ibrutinib is, a highly effective drug. It changed the field in CLL dramatically, but it is not a highly specific and selective BTK inhibitor. There's obviously lots of off-target kinase inhibition, and that leads to quite a number of the toxicities that we have sort of been observing in our clinic and gradually understanding better. So obviously GI toxicity, bruising, bleeding, arthralgia, myalgia, cardiac side effects, etc. So I think I think it became evident over time that there was space to develop something more targeted, more specific, and I suppose that's where acalabrutinib and zanubrutinib, just about in parallel, acalabrutinib a bit further along the treatment pathway, but both are obviously covalent BTK inhibitors, so they inhibit BTK signaling in exactly the same way as ibrutinib does. So no real reason to think that they would be more efficacious, particularly. And actually, that's certainly what we've seen really up until now, at least with acalabrutinib, in terms of the Elevate relapse refractory study and so forth. But the toxicity profile for both agents is better. I think we have enough evidence to suggest that, both in CLL studies so far. The zanubrutinib study is not quite as mature as the acalabrutinib study has been, but we've seen pretty much better safety profile across the board in terms of all those toxicities I just outlined. And so covalent BTK inhibitors, the management will, depending of course on availability and cost and all of those other factors, which are all of course important in terms of what you can use in your clinic. But I think if you had a choice now, certainly people would plump for a second generation BTK inhibitor because of the toxicity profile. And so we have seen this big shift towards the use of and obviously acalabrutinib's got a frontline and relapsed license at the moment. And certainly in my clinic at the moment, I don't use any ibrutinib now. I only use acalabrutinib when I use a covalent BTK inhibitor. So it's just been interesting how kind of quickly that's shifted. And actually, if you do create a safer drug, even if it's equally effective, overnight it can take the place of the less safe drug because nobody wants a more toxic drug in their clinic. So it's kind of an interesting phenomenon, actually, which is quite a relatively new to hematology, that you can inhibit the same target, have a safer drug, just as effective, and use that drug because of safety profile primarily. And then, of course, the advent of the non-covalent BTK inhibitors. Now, these are obviously much earlier, and they do have a different biological rationale because they don't rely on the CYS481 residue for binding. And I think that's the key thing. And certainly the xenograft models and so forth, the preclinical data suggests that these agents are just as active in people who are effectively resistant to covalent BTK inhibitors. And I suppose the beauty of these agents is they would be, in theory, effective in people who were resistant to any of the covalent BTK inhibitors, because primarily the dominant mechanism of resistance is the CYS481 mutation, so not allowing covalent binding to that BTK residue. So and the biological rationale has matched with the clinical data so far. The response rates so far with the studies that we've seen are really kind of sort of unprecedented in the kind of patient population that have been studied so far. And they're clearly very active agents and seem to work equivalently well whether you do or don't have a CYS481 mutation. And certainly the data presented at ASH last year suggests that. So this drug, in terms of pirtobrutinib, and there are other non-covalent BTK inhibitors actually in even earlier development. There's a Merck drug which is being developed as well at the moment. They are potentially again going to add to our armamentarium. Now, of course, there's all kinds of interesting questions that throws up in terms of when you'd use each of these different kind of drug classes, but undoubtedly they'll be extremely useful, particularly, in the initial phases after patients have become resistant to covalent BTK inhibitors, I think. So, we've seen this shift, going back 10 years to no targeted inhibitors, and very soon we might have 3 classes that we would routinely want to use in our clinics. And I've kind of excluded PI3 kinase inhibitors from this because not that they're not occasionally useful drugs, but they are obviously much more toxic. And I think if you have covalent BTK inhibitors, non-covalent, particularly with the pirtobrutinib adverse event kind of profile that we've seen so far, which is, extraordinary, actually. It's early days. It's a heavily pretreated group of patients, and the tox data looks very good. And then, of course, venetoclax, which we know is generally tolerated really quite well. So I think if you have those 3 agents, very soon you've moved into an era where even if you use them all as monotherapies with or without a CD20 antibody, for example, you can see how people will live for potentially decades without having even to touch chemotherapy, for example. So the treatment paradigm has just totally shifted, which is, remarkable, really. And
in a shift, in a revolution, I would imagine medicine, it never stops. So what do you think at the moment are the most unresolved questions or unmet clinical needs in your opinion for CLL?
Yeah, it's great. It's a great question. So and this sort of changes all the time, doesn't it? With new agents coming along, your unmet need shifts all the time. So if you'd asked me that a couple of years ago, I'd have said something different to today. I mean, I suppose the kind of clearest unmet need in terms of just routine clinical practice at the moment is the patient population who have been exposed to covalent BTK inhibitors and a BCL2 inhibitor. So the so-called dual exposed patient population. And they can either be stopping those agents because of toxicity or resistance. Of course, most commonly it will be resistance. Now, of course, that isn't a big population at the moment because loads of our patients are all responding well and kind of chugging along very nicely on either of those 2 agents. But there will come a time where these patients cycle through these drugs and they progress through them. And obviously I've mentioned pirtobrutinib. It's not approved or licensed now. So of course it's been accessed in clinical trials, but until it's approved, I think we have a space there following those 2 kind of classes of drugs where actually there is a real unmet need. And certainly at the moment, people are still considering things like allogeneic transplant, potentially CAR T cell therapy in clinical trials, trying a PI3 kinase inhibitor. That the evidence for that is not particularly good. Actually, there's actually not much data there, but what the data that is there, it doesn't show that response is particularly durable in that setting. So I suppose, that naturally is the kind of space where there's room for new development. Now most patients, that won't be a massive deal because most patients are older, have comorbidities, will be very well served by BCL2 covalent BTK inhibitors potentially for many, many years. So you will find that a lot of patients will actually kind of derive a functional cure from that combination of those 2 drugs because they'll have 10, 15 years remission response duration to those agents. But there are younger patients, of course, in our clinics that we all know and manage that have high risk disease features, immunoglobulin gene, unmutated disease, P53 deletion mutation, etc., that we know will at some point progress through these agents. If you do large enough pooled analyses, you'll find that P53 unmutated disease, complex karyotype always falls out as poor prognostic features. So I suppose in light of all those things, that there will be a younger group of patients where I'm certain we'll be dealing with disease resistance to those classes of drugs. And then it will be a case of, well, okay, do you use a non-covalent BTK inhibitor? How long do you use that for? Do you use it for a bridge to something else, CAR T, allogeneic transplant, etc.? I think those will be some of the questions that we'll be needing to look at in the future, actually. So yeah, but I think certainly promising that more and more of these agents are coming along. And certainly in your really high risk patients, you always just need, in terms of how you manage people in your clinic, you always need to be confident that you've sort of got a reliable salvage regime up your sleeve, so that should they progress through whatever drug it is, you've got something there next. And that used to be venetoclax, and then hopefully now it's going to be pirtobrutinib in the next few years. So we used to obviously think about bridging people to, say, allo after venetoclax if they've had, chemo, then ibrutinib, then venetoclax. You'd get to the point where you're like, we need to, if you've got a young fit patient who's got high risk disease, you think, I need to get this person to allo or whatever. Whereas I think that same question will happen. It will happen in people who are being bridged with Perto initially, I suspect. But of course, that population will be smaller because more and more people will just have had longer remissions, and they'll be older and less able to, for example, tolerate the toxicities of transplantation. And I suppose CAR T cell therapy needs to develop more in CLL. We need to understand how we can improve T cell function for CLL patients. So that's how I see things at the moment. And then, of course, the big unmet need that still exists is those patients who transform, and obviously Richter transformations are sort of a big topic in itself, but clearly we're not sorted there by any stretch of the imagination. So that's certainly a field that I have a kind of passion for improving, and we have studies in Oxford kind of leading on this, but I think it's a hard area, and it's difficult to do clinical trials in as well. So it's really hard to kind of improve on outcomes.
But it's the perfect, you have a perfect outline, because that would be my next question. And I hope I didn't disrupt you, because my neighbor is also renovating his flat, and they were like popping against the wall. Sorry for that.
You carry on. No, I can't hear anything.
Would you just point out a bit what Richter transformation is, and how at the moment we best manage it, if you could say that it's manageable?
Yeah, sure. So Richter transformations are kind of, or Richter syndrome is a kind of term for a change of histology, most commonly always from CLL, but most commonly to a kind of diffuse large B-cell lymphoma type histology. There are occasions where you can get transformation to Hodgkin type Richters, which obviously has a very different kind of biology, different treatment, etc., actually different prognosis. Very, very rarely you can get transformations to things like lymphoblastic lymphoma and Burkitt's. Fortunately, they're extremely rare. So most commonly we're dealing with transformation to a DLBCL type histology. Now, these diseases are not, however, if you look at them biologically, particularly similar at all to kind of de novo DLBCL that we're used to looking after. You get a lot of aberrations of MYC, Notch1, TP53, actually kind of the and some of the cyclin gene regulators as well. So mostly to do with either anti-apoptosis or cell cycle regulation. And biologically, this disease entity is particularly challenging. So I think if you look historically in the kind of era where multi-agent chemotherapy is used, and actually there are quite a few intensive regimes that have been trialed with this disease entity, the median progression-free survival typically ranges between about 3 to 9 months, and the median overall survival between about 10 to 12 months. So that is clearly a very distinct change from the typically indolent disease behavior that you see with the underlying CLL. So Richter transformation, certainly for many of my patients still now, is obviously a very feared complication of CLL. For those who like to go away and read about all the bad things that can happen to them. Fortunately, not everybody does. How is it treated now? I think we're still in an era where most people would consider anthracycline-based therapy in combination with a CD20 antibody as a kind of sort of standard approach. Not because anybody's particularly happy with that, because the median progression-free survival is still roughly around about 6 months or so. We did a UK study a few years ago of a combination of ofatumumab plus CHOP and then ofatumumab maintenance, and the median PFS was about 6 months or so. That still remains the largest published prospective clinical trial ever done in Richter's, and I think there were 43 enrolled and then 37 evaluable or something like that. That it was not a big phase 2 study. So I suppose that therein lies one of the challenges. Actually developing a really good evidence base in Richter's is really difficult. Some of the newer agents look to have some promise. Certainly PD-1 inhibitors look to have some activity. BTK does have activity. We recently published some experience with acalabrutinib. There is activity. Overall response rate is about 40%, but non-durable. So I think it will be a case of actually both understanding biology, enrolling into clinical trials, doing associated biological studies in these patient populations, but also potentially combining the tools that we have at the moment. So there are studies, for example, there's a study in Germany that's just starting to enroll of a PD-1 inhibitor plus a covalent BTK inhibitor. So I think tislelizumab plus zanubrutinib, so a combination of 2 drugs and potentially both effective. And in the UK, we've got a randomized study called the Stellar trial, which is R-CHOP chemotherapy versus R-CHOP plus acalabrutinib. So that's actually the first. I feel like I'm kind of providing kind of like a plug for our center and so forth with our Richter study, but it's the only randomized study in the world, I think, as far as I know, and it's R-CHOP plus R-CHOP acalabrutinib versus R-CHOP acalabrutinib. And so I suppose that will attempt to answer, the question as to whether the addition of covalent BTK inhibitors can improve outcomes in these patient setting. And then just the final thing to say on Richter's is outcomes very dependent on when the transformation occurs. So if you get transformation occurring, in the relapse refractory setting after prior novel agents, that's, properly bad news. Median survival in that setting is only a few months based on the data that's in the literature. But if you're you do get occasions where people are untreated CLL and you get de novo transformation having never had treatment before. Mm-hmm. And actually, if you've not got a P53 deletion and you transform in that setting, actually patients don't do anywhere near as badly, and you can actually potentially cure some patients. So I think a combination of when it occurs is really important, and what patients have been exposed to before is prognostically very important. Mm. But it's a hard area. It's really hard to do clinical trials, and we need to do our best to keep doing them and try to enroll patients in. The other thing is when patients transform, they often older, might have comorbidities and so forth. And actually it's quite difficult to get people onto clinical trials because of the pace of the disease and the relative rarity and the lack of trials that are generally open in a lot of centers. It's quite hard to put people into studies. So therein lie kind of a range of challenges in this disease.
And maybe when we tend towards the end, we live in a pandemic, and I'm sorry I need to ask this question because I think particularly in CLL, the COVID pandemic was really influencing people's lives because of the vaccine response problem, etc., due to therapy, etc. But what would you say? How did the pandemic influence you in your work, in your life the most, and particularly also CLL patients?
Yeah, I mean, great question. I mean, there's so many ways in which it's influenced kind of all of our lives, I suppose. Just to pick out a couple of key things, really, I think we've got better at knowing how we can monitor some patients sort of at arm's length, i.e. keeping them away from hospital and perhaps understanding which disease entities it's sort of safe to manage people from a distance. I think we've gradually gaining a better understanding of which drugs are a problem in terms of vaccine responses and what you might need to do about those problems. I don't think that's sorted though by any stretch of the imagination. I think we've certainly changed some of our treatment paradigms in lymphoma, or certainly become a little bit more nervous about some, maintenance rituximab in follicular lymphoma might be a good example where, certainly its utility is debated a little bit more in the COVID era. In terms of CLL, what have we done differently? I think, going back to that kind of managing patients from a distance so that they can safely avoid coming up to hospital and so forth. We've delivered a lot of our, during the time when the peaks of the pandemic were at their worst, we've delivered a lot of treatment out into the community. So a lot of the kind of tablet-based therapies that we use, I'm thinking mostly of acalabrutinib here, we've been able to deliver a lot of these therapies out to people's homes. Because the agent has a good toxicity profile across the board, if patients are monitoring their own blood pressure and and so forth in the community, we've certainly at least intermittently been able to monitor people over the phone and manage people like that. Obviously, there's a tension there between wanting to make sure people are okay and see them face to face, and you obviously lose a lot in terms of clinical assessment via not seeing them. But certainly, we've done a reasonable amount of that where we've had to, and yeah, and then I suppose there's the kind of counselling element. There's the very big counselling element with patients about just being able to do our best to try and get an understanding about individual patients' risk. The number of times I've got asked, can I go to my granddaughter's wedding in the last 2 years, it's been extraordinary, really, or equivalent type questions. And actually they're so hard I hate them because they're so hard to answer, because of course you want people to get on with their lives and do what they want, and you've got to make some sort of reasonable, you've got to try and help people who are in that kind of position, but also it's really hard to make very objective decisions about people's individual risk in terms of what they're doing, how they're interacting, how they're socially distancing, all this kind of stuff. But that's been I found that personally very difficult, partly because I can't give people always the answers they want. So yeah, I mean, there's so many things that have changed the way we've worked. Obviously, we've done loads of kind of our own kind of multidisciplinary team kind of tumor board type meetings via Zoom, and interacted a lot more kind of, I suppose, electronically rather than face to face, and I find it quite draining after a while. But yeah, I suppose that's where we're up to. I think we're probably learning how to best manage some disease entities kind of from a distance, and there are diseases that are just better, more easy to manage in that regard. But yeah, I think there's still a lot of learning to take place.
And finally, when we see when the field like hematology is evolving, then it's obviously also evolving in competition. So the field gets more competitive between maybe hospitals, countries, etc., access to treatments, for instance. But in that regard, what advice would you give to someone, to a trainee who thinks about going into hematology? Maybe just key points. You alluded to it at the beginning from your personal perspective, but what kind of key points would you have helps trying to navigate you?
Yeah, I mean, it's a great question, and obviously everybody's a little bit different in terms of what they want. So I think that the key thing I would say is be honest with yourself, and get kind of talk to people who are kind of who are kind of sort of safe and dependable and helpful people to talk to you about what you might want to do. Because I think that's key. The worst thing you can do is not be true to yourself in terms of making your own decisions, because I think then you'll just end up sort of unhappy whatever you're doing if you're doing it to sort of please other people or what whatever. And that's true in lots of areas of life, not just hematology. And then I've obviously talked a lot about CLL lymphoid disease today. There's clearly lots of fascinating areas of hematology in across the board, and lots of people will find great fulfillment and interest in lots of areas. So I think there's no sort of one size fits all approach. I think if you're inquisitive about kind of clinical research, then there's loads of stuff to do. I suppose my if I were to give some advice about why I've chosen lymphoid disease, particularly, and why I have particular interest, I've sort of chosen areas where I think there's a lot going on. I think there's lots of new drugs coming along, and also some disease entities that aren't like sort of sorted, if you see what I mean, but that are common enough and common enough to do sort of clinical studies with. So you kind of want a tension between something that lies somewhere around that. If you're thinking about, okay, well, I want to do X or Y. There are also, of course, some disease entities that there's just that much more kind of sort of competition in terms of level of just broad level of interest in the pool of physicians that are actually kind of engaged and interested in it. So CLL is actually kind of quite a sort of competitive space if you look at it that way, because it's quite a common disease. You can do randomized trials and so forth. So from that point of view, in terms of sort of making a name for yourself, if you like, that's actually quite difficult in kind of very competitive disease entities. Probably AML is something not dissimilar, actually. It's kind of looked as this big disease that needs sorting. That's great, but of course that's going to attract lots of people to sort of want to sort it. So I suppose whenever you're thinking about, I don't know, personal interest, if you move forward in a field, you need to just kind of consider that. And you also need to, if you're looking to kind of develop in, like, say, national roles or so forth in your own country, if this is what you want to do, then you also need to think about sort of who are those with grey hairs 10, 15 years older than you that sort of are controlling the field a little bit, and actually where's your opportunity? Because actually, just from a practical point of view, that is actually quite important, because you can be brilliant and know everything about a disease entity and have all the ideas in the world, but if someone with grey hairs who's 20 years old and you controls everything, then you're sort of stuck, basically. So that's they're just a few thoughts, but I think the most important one of those are just be like really honest with yourself about what you want to do, and do something you end up loving, because then it won't feel like work, actually. And you'll get out of bed and you won't feel exhausted about the day ahead, and I think that's really important, because you're going to be doing this work for 30, 40 years. So do what you enjoy, basically. Don't do stuff to please other people. I think that's the other thing.